So good morning, everybody. Today is our, as usual, the device class. So device, we are just going for the basics. So one of the important what you call problems in device is crosstalk. Crosstalk means there is a alternative chamber are communicating in a wrong way. And what happens when patient is pacemaker dependent? When the device has to pace it, it will not pace it. And if a patient is of complete heart block, when the atrial activity is taken as a sensing in the ventricle, it will not pace. So those type of problems sometimes misinterpreted as a capture, or you can say sensing, no, sensing problem of the device, and sometimes patient dies also if it is not properly seen, or beats has not been properly been detected, means one or two crosstalk has not been detected while interrogating, or the patient is coming with some sort of giddiness. When they are coming, the ECG is totally normal, but when we are interrogating, we are finding some abnormalities which may be the cause for his giddiness. And in that evaluation, it is very essential that we should be mindful that probably we are dealing a case of crosstalk. So today, one of the what you call presenter, Mr. Madhukar Deva, he is IBHRE affiliate, and he will be giving the presentation from the Boston company, how the device how to detect the crosstalk, and how it is going to be interrogated and later on be corrected. What are the ways and means to detect it, and what is the consequences also. So over to Madhukar. इन्होंने एसी ऑन नहीं किया, आई थिंक. Go ahead.
Good morning, sir. Good morning, all. Thank you very much, sir, for the opportunity. So today I will take you through the crosstalk, which is very, very essential, very important to understand what is happening, how this crosstalk is happening, and what are the remedies to overcome this crosstalk. So basically, the crosstalk. What is crosstalk in terms of a pacemaker? So pacemaker crosstalk is when a pacing stimulus intended for one heart chamber is mistakenly sensed by the other pacemaker lead. That means, so if the atrial spike is sensed by the ventricle, so the ventricle lead is over sensing, and there will not be any paced beat in the ventricle when it is required. So that leads to the inappropriate pacing inhibition, and we are going to see a loss of capture. We will observe there will not be any ventricular activation there, followed by, so we will see a loss of conduction and consequences problem. Patient may have syncope, fainting, and other stuff. So this can happen only in dual chamber pacemakers or in a biventricular pacemakers. So it's a form of oversensing where the pacemaker is incorrectly interprets a signal as a native beat. So potentially caused missed or inhibition from the pacemaker side. So this, if you carefully look at the EGM of a pacemaker, so when the atrial stimulus, which is indicated in the red in mark, which is AP at the round circle, so the immediate within a very short period of time, so you will be observing the ventricular sensing in the ventricular channel, which is not the true ventricular sensing, which is the stimulus of the atrial pacing spike, which was sensed subsequently. So there is no ventricular pacing when the patient is required for this. So you will be able to see a long pause. So this is how we will observe in a day-to-day practice when crosstalk occurs. So what are the major causes of this crosstalk? So it is basically the increased atrial outputs because the higher thresholds in the atrial lead, high ventricular sensitivity. So we will take you through that. And unipolar pacing is one of the other cause. So basically, all these crosstalks are majority of the time used to happen in the older generation pacemakers, because at the time, so we don't have bipolar pacemakers as such. In present generation, so we have all our pacemakers are bipolar. However, when it is required in a emergency situation, or the any concern happen to the lead, so it switches automatically to unipolar to save the patient. That is the other thing. But in olden generation, we used to have only unipolar pacing devices as well as the leads. So cross proximity of leads. So this means like the when we implant the leads, so in the cardiac chambers, right atrium and the right ventricle, the space between the two leads are very close in placing the leads. So dislodgement again. So one of the other reason for this crosstalk. The consequences, one is the inhibition of ventricular pacing majority of the time. So patient is going to have symptoms, and the pacemaker syndrome is also going to happen by having this crosstalk. So what is the solution? So basically, the solution is the safety pacing to avoid the inappropriate inhibition in the RV. It prevents the patient from the asystole by guarantee a pacing ventricular pace in the presence of crosstalks. I will take you through how to differentiate or how to identify what is safety pacing and what is how it will help to avoid the asystole to the patient. So if you closely observe, so the crosstalk is happening only when the atrial pacing, which is AP, presence in the EGM or the particular sequence. So the very important thing is like we need to identify whether it is crosstalk or whether it is oversensing, whether it is the loss of capture from the ventricular lead. That is very essential to understand, and the response from the pacemaker to overcome this issue. So safety pacing, as we discussed, which is the safety mechanism to overcome this crosstalk. Prevention. So anyway, so by doing this safety pacing, we are going to uh, prevent the asystole from for a particular patient. So we are going to improve the patient quality and the safety that we are offering by putting a pacemaker for a particular patient. So there are few programming options. So what are the programming options to avoid the or to reduce the incidences of the crosstalk? One is the atrial amplitude or the pulse widths by lowering the number, so that the occurrence of the crosstalk will be minimized. So program the lead polarity to bipolar. However, nowadays all the leads are bipolar, even the devices are bipolar. So the incidence of this crosstalk is in present generation is very less. So make the ventricular less sensitive by raising the sensitive value. Sometimes when we keep the auto sensing adjustivity in the ventricular and the atrial channel, so because of the very sensitive from the device side, when the atrial pacing spike occurs, so there may be a possibility to that pacing spike will be sensed as a ventricular event, and the subsequent inhibition will happen. To overcome that, particularly in pacemakers, so we can have the fixed sensitivity instead of the auto sensing adjustivity in pacemakers. So prolong the ventricular blanking. So this is also present days, which is auto in majority of the companies. So the pacemaker, if it sends something during the blanking period or during the refractory period, so it will recognize as a noise, and it will keep on increasing the noise window. So reposition the lead. So that is the ultimate solution for this if the lead proximity is very close by in placing the leads. So the last resort is mode change. So this is the if we are not able to operate for a particular patient at this time by for the lead reposition, switch the mode to single chamber pacemaker, which is VVI in mode, so that we can um, we can assure the ventricular pacing for a particular patient when it is required. So I will take you through Boston Scientific algorithm how to encounter crosstalk. So different companies has different mechanisms. So majority of the companies, they will have the fixed AV delay, so that will be after expiring of that particular AV delay, so the device will pace. So with Boston Scientific, so we have the AV delay in the ventricle, which is once the atrial pacing is initiated, so the ventricular blanking period will occur. So after the ventricular blanking period, so it will look for the cross detection window. That means, is there anything which I am able to see from the other channel? So it is going to look with that for a particular period of window. After that, after a particular time, then the device will look for, is there any ventricular activity is going to come or not. If not, so the pacemaker will pace from the device. For example, if you look at after the atrial pulse, so the ventricular blanking period will started. That is about 60 milliseconds. After 60 milliseconds, the device will wait for the another 60 millisecond window. If it senses something during the first 60 milliseconds, the second 60 milliseconds, the device will wait and it sense. If the device is able to see anything in the first 60 milliseconds, then it increases the AV delay by another 60 milliseconds, where it started. Example, if after in the first 60 millisecond window, if the device is able to see something at the 30 milliseconds window, that means from 30 milliseconds, again it extends to 60. So first 30 plus 60, 90 milliseconds are happening. After 90 milliseconds, if something comes, that means there is no cross window area there. After 90 milliseconds, the device will look for the ventricular activity. If ventricular activity is not happening there, so after the expiry of the AV delay, so the device will deliver a pacing spikes to assure the ventricular capture. So this is how Boston Scientific device will deal when the crosstalk is happening. So for example, in the red color, if you look at, so after 60 milliseconds, if something comes, so it is a kind of noise. If you closely look at the noise kind of EGM, so always the noise will be persistent and continuous towards the EGM, so that the refractory period will keep on increase. But however, once the refractory period is reinitiated, but it will not violate the LRL, it will not violate the AV delay. So during that time, so it assures the ventricular pacing for the patient, that will be taken care. The ventricular pacing activity will be assured for the patient to avoid the asystole. So how to navigate in the programmer? So for example, if you go to the settings, from there, like if you go to the timing, I'm really sorry, I think the size may be little lower in size. So this is the programmer screen. Once you go to the parameters, so in the settings of the normal Brady RACRT programming, so below left side, so timing rate enhancements window will occur. If you click on that button, so it takes you to the blanking. So nowadays, all the blanking periods, there are 4 variety of blanking periods that will come. So all are smart, except one is about 60 millisecond. So that will be, we can program even the smart delay. Smart programming means like the smart option will come for 15 milliseconds. From there, like if required, if the device is sensing anything in that first 15 milliseconds, so it keep on adds that 60 millisecond window to that. So if there is our requirement is about 40, 50, 60, so up to 200 milliseconds is programmable with Boston Scientific device, and so we can do that. So there are in fixed models, the fixed means the fixed sensitivity for a device. So there is a slight variation from a pacemaker side to the CRTP device. So when it comes to the pacemaker, the nominal is the starting smart window starts at 15. However, in CRTP device, so very much particular, and we need to do the therapy with the aggression. So the smart window will be about 85 milliseconds in the initial stage. So this is how typically, so we are going to observe while observing the strips. So if you closely look at the complex where the arrow mark is, so there is a atrial spike. It was delivered, but there is no capture as per my understanding. Even after that, so that was sensed by the ventricle lead. If you closely look at the V sense at the arrow mark, so there are two spikes, means like there are two arrow marks in the annotation mark, two lines. That means one is the device the first one belongs to the device sensed the atrial pulse, that is one. And the second thing is, after a delay of 110 milliseconds, so the device was delivered a pacing spike. Even though, so the gap is very minimum from the initial pulse to the second one, so the device is not able to mark as a V pace, but this is a safety pacing that we are going to see. This is one of the other beautiful example with the older generation pacemakers. Nowadays, like, we will not be able to see this much of this kind of demonstration in the regular day-to-day practice. If you closely look at the EGM point of view, there is a atrial spike in the round. After that, so the device was not able to deliver the ventricular activity. It is purely because of the crosstalk. The next beat was assured with a safety pacing. You can see the 110 milliseconds after that, so the device delivered the uh, what do you call the safety pacing pulse. And it was, so in present generation there are no safety pacing incidents are happening. But however, so if there is, the atrial threshold is about 3.5, by mistake the device automatically switches. If you keep the auto capture on, so it switches automatically to 5 at one pulse width followed by unipolar pacing configuration. In that particular situation, so you will be able to see Vs followed by the Vp within a short period of 110 milliseconds. So that is the safety pacing because of the crosstalk which was happened for a particular patient. This is one general slide for each and every one, our observation. So safety pacing is almost always triggered by a R wave. Crosstalk has become almost non-existent due to bipolar polarity of the leads and lower programmed outputs. So if you closely look at the Medtronic, safety pacing is about 110 milliseconds. Ventricular safety standby, which is by Abbott, about 120 milliseconds. AV safety delay of Biotronic, it is about 100 milliseconds. So committed period is called from Sorin, which is about 95 milliseconds. So this feature is triggered when the ventricular channel senses in the first part of the AV delay, right after the ventricular blanking period. So these numbers are very essential when you are encountering a troubleshooting, particularly when the patient says, or if the EGM was stored with a atrial pacing followed by a loss. So this will be one of the tip that we can use. If the safe pacing is happening at 95 milliseconds in the post cath, so that means like something is, even our programming is at 120 150 milliseconds or 110 milliseconds, the AV delay pacing is happening, means so we need to have a check once whether the lead was dislodged or because of higher output in the atrium, so the other channel is sensing. So we need to make sure before sending the patient back to home. Thank you, sir. Thank you very much.
Lastly, how you are going to identify, how the device is identify the crosstalk? Means now bipolar we are not expecting, but how it is going to identify it? Like a lead is been there in atrium, all of a sudden it is fallen the ventricle.
So in the older generation devices, sir, so we don't have even the marker channels or the EGMs for each and every device to storage. But in present generation, all the companies with the capacity of maximum storage, so we will be able to see all the EGMs and the marker channels Even if you switch on the marker channel in the programmer, sir, you will be able to see where the A pacing is happening, what is the AV delay which was after the device was weighted, and is there any ventricular spike after that, like how long the device was weighted. So all these will be measurable for the device, basically to address this crosstalk, sir. So we will be able to see normally the device will look at the atrial pulse majority of the times, sir, in present generation, as per my understanding, correct me if I am wrong, if the atrial spike is happening, because majority of the time because of the atrial auto capture, if we switch on for a particular patient, the atrial the atrial, to confirm the atrial capture, so the evoke response is very very minimum to the device. If it fails, so it is even it is not the true failure from the device side, but in one of the other incidences, sometimes the rates are higher in the atrium, sometimes if it is not able to confirm the capture, so the outputs will automatically switch to 5 one pulse width as well as unipolar. So in that occasion, so there is a high possibility for the crosstalk to happen for the device. However, if that happens, so the device will base at a fixed AV delay with Boston Scientific and safety measurements like 110 milliseconds from Medtronic and vice versa.
So, that I got it, but I just wondered if the actual lead is there, it has fallen just near the front.
Sir.
Like normally when you have screen, sometimes it falls. And it has just given what is called pulse. And the ventricle is also sensitive, okay, it is a normal sensing. Whether it is going to do it will take it as a crosstalk, or it will just face that situation.
So, in that situation, sir,
how the device will do it?
So normally, sir, if you closely look, so I am never encountered this, but so there is a thing like if the atrial lead was dropped to the ventricle, if it generates a pace, so obviously it is going to deliver a depolarization. However, it was in the ventricle. We intended to keep this lead to generate the atrial pulse. If the lead is already dropped to the ventricle, if it is in contact with the myocardium there, it delivers our pulse subsequently. So it is going to have the QRS complex instead of the P wave, followed by, so after 120 milliseconds it waits. So after by the time, so that if the device from the ventricle lead, if the device is not able to sense anything, so this 110 milliseconds of the AV delay, so that you will typically looks like this. So this is the pattern that you are going to observe. If you closely look at the arrow marks, the first atrial beat, which was very close to the almost equal to the ventricular capture, followed by something will sense by the device. So after 110 milliseconds, this is a typical Medtronic slide. So after 110 milliseconds, you will be able to see another spike. But that may not result in the capture. Thank you, sir. Thank you very much.
Thank you, Madhukar. So it was very insightful. I think I will summarize it what he was saying, because the language will be very technical what he's tried. So first of all, understand what basically what are the basic requirements. So when we are having a pacemaker and we are having two leads, one is the atrium, one is in the ventricle. So these behaviors of what we call crosstalk means talking between the two chambers and the two leads. So this lead is when we are implanting the pacemakers, we are expecting what we call a behavior which is predictable. Atria has sensed something, it will wait for a particular time, maybe 120, 140, 160, whatever we have programmed it. After that, there is a ventricle pacing. So this is the normal behavior what we are expecting. So crosstalk means atria has paced and ventricle is thinking that ventricle has paced or ventricle is having some activity. So what is happening exactly? What abnormality it is? Atria has paced and ventricle is sense that ventricle activity is there. So what abnormality it will be taken? He has already... No, crosstalk is the what you call final interpretation, but what exactly it is? Abnormal. There are two things in the pacemaker. One is pacing, second is sensing. So it is a pacing problem or it is sensing problem? Yes. So it is basically a sensing problem of ventricle or other chamber. When one is contracting, other is sensing, which it should not. So when the leads are very far, it is less likely. When leads are nearby, it has contracted, it is also sensing it. And it will happen in one situation when, if you are knowing or not the anatomy of heart, the appendages, left and right appendages are like that, clasping the aorta. Aorta is inside and it is going like this, and it is falling on the upper part of the ventricles. So if you can see, it is like this is if you are thinking, this is the what do you call left right appendage, and this is the RVOT. So it will be clasping like this one. So when we are screwing here and we are putting the lead in the RVOT, sometimes the what do you call places in which we screw, there are three places. One is apex, mid-septum, and RVOT, to get a better threshold, and sometime for the myocardial depolarization will be less, means the QRS will be narrow if you are going upper. So in that scenario, the atrial as well as ventricular leads are very nearby. And it is possible that when the atrial thresholds are high or it is very nearby, when it is contracting, it will immediately pick up. So in the modern time, when we are using the bipolar lead, the only one position where it is very, very common is, number one, when the leads are in the atrial appendage and we are put the lead in the RVOT, or lead has misplaced. What I was asking the question. If the lead has been kept in the atrium, it is fall in the ventricle, and all of a sudden patient is of complete heart block, you don't know, all of a sudden it has sense, okay, contraction is there, but it is not that forceful, or it has not been taking, because the sensing is happening, the contraction has gone in a wrong time, and the behavior what he was saying like that here, sorry. So in the behavior, this is the atrium. I think I have to swap it. So here you can see this is the P wave. Sorry, this is the P wave followed by the spike. So it has sensed it. Since the ventricle is alert enough, we use word VSP, ventricular safety pacing. So to avoid crosstalk impact on the rhythm, ventricle has sensed something that, okay, it may be crosstalk, it is falling in a window where there should be no noise. If anything has been captured here, it will immediately give a second spike. They don't want that we should fail the ventricular contraction. Are you getting this point? So there is one window, one is called blanking period. That time the ventricle is, he was using two words. One is called blanking, second is called refractive se pehle that window, that cross detector window. These two things are different. Blanking means I am blind. Whatever atrial activity is happening that time, I am not going to think about it. So that window is around 60 seconds. Huh? So it is 60 seconds. Atrial contraction means when the pacing is going on, ventricle is saying I am not going to sense anything for next 60 seconds. After 60 seconds, if any activity is there, which can be sensed by the ventricle, so that window also I am going to specify. Some activity has come, maybe APC I will not say, some noise has come and ventricle is thinking, okay, this is a ventricular activity. It is captured, means atrium is having some activity. After blanking, some noise it has detected from there. So it has detected. So that is called, that window is called ventricular sensing, cross detection window. So cross detection window is the time in which our radars are ready. The time it captures, immediately give one beat. What it is doing, it is giving a beat which is going to capture, means it is not waiting for 120 millisecond. It is just avoiding that sensing should not have its impact in a dependent patient. Are you getting this point? Atrial pacing, blanking, wait for a window, anything activity, if it is coming, immediately should give. So that window here, it is, you are seeing, this is fixed. So when the beating is happening, like two small means two pulses are coming, and these pulses will be having what he was saying in the end. This every pacemaker company is having its what I call specified. So for the Medtronics is 1 to 10, for St. Jude 120, Biotronics 100, Sorin 95. तुम लोगों का भी 95 ही रहता है ना. So between 95 to 120, if two spikes are coming, until proved otherwise, it is VST is happening. It is not a bad thing. We have to think about it. It is detecting some noise. Why noise is happening, that we have to detect it, and it is a safety pacing. So ventricle safety pacing we call it, and it is a response to avoid non-capture, or no, not to say over sensing in a dependent patient. Dual chamber pacemaker for complete heart block. Patient has gone home, very good. He is very happy. Patient has been kept by somebody by unipolar mode. Unipolar mode, he just for the what you call sensing point of view. This over sensing has led to the atrial activity. It is not paced. Patient gone complete heart block, die. And he will say that when we are doing the fluoroscopy, we will see lead is very good, and the reason is it was crossed. So ventricular, we call as a ventricular unipolar mode is not a good thing. Either it is for the pacemaker or for the ICDs. Put a unipolar mode for atrium, not a problem. But unipolar for, if sometime we have to do it because the lead is having some issues, like it is capture is not happening, but we are keeping the unipolar mode also. Unipolar means lead is here and can is here, means PG is here. So this is the area in which it is going to capture all the activities. So its radar is big. If you are keeping a bipolar lead, what we normally lead, so polar activity is here only. So it is not going to detect what is happening here. So bipolar means smaller window, smaller antenna, and unipolar means bigger antenna. So bigger antenna, it will capture a lot of noise. So mostly we keep bipolar. Bipolar aane ke baad se these activities are not commonly detected. But what are the scenario? Number one, RVOT and RA appendage leads has been very nearby, and one threshold is high. It is giving more thing, and it has been captured. Or lead has fall down. The patient is dependent. Patient is having no atrial activity, and in tap when the atrium is there, it is ventricle is already somewhat, and so it is waiting for the next, and the patient is going to complete heart block. So all sort of, and when you are bringing the patient, you are seeing leads are all proper, and nothing you have to do. First, make the patient ventricular dependent, means single chamber pacemaker, and later on, if things is there, you can change the mode, no, not to say mode, the thresholds. Okay, for timing, you can reduce the sensitivity of the ventricle leads. So all those three protocols we can. And if it is a fall in the left atrium, bring the left atrial lead in the right position. So this should be then okay.
And majority of the time, for our easy understanding about the intervals, these are non-physiologic intervals.
Yes.
If you look at the ABD, which we will call it as normal, 120 to 200 we will call it as normal. In pacemaker predominantly, so we will keep 120 and 150, 180 just like that. If you observe something in the pacemaker, that means something is that we need to identify. So
this is a cross detection conduit. So VV, what he is saying, a ventricular blanking period. It is blind. It is not going to see any activity. It is blind for almost what is 60 seconds. After that cross window, it is opening. It is watching any activity is going or not. If detected, immediately will give a pace, and that will be having two lines, one small and big. So these two small big will means one is coming with a 5 amplitude, and the time period will be very small. And after that, it will be inhibited or not. That depends upon the if it is detecting anything activity. So this is the thing what is takeaway for all of us, that crosstalk is not a common phenomenon nowadays. But if you are facing a patient coming with a complete heart block in a dependent patient and leads are proper in position, probably it may be a crosstalk, it may be a unipolar lead has been kept, and the window is big, the antenna is big one, and it is detecting the atrial activity. That is very, or one lead has fallen, the other means atrial lead has fallen, you are seeing straight line. The reason is, even though ventricle lead is proper, it is not pacing because it is detecting the atrial activity and silently sitting. Got it?
Sometimes, sir, even that is very, very pertinent to our present day's practice. Crosstalk may not be common nowadays, but if the lead is pretty old, about 15 or 10, 15 years old, unfortunately, the patient insulation was broken. So, in present generation device, the device will switch back to unipolar, and this may happen to that particular patient.
So wherever unipolar is coming, this type of problem can be there. Usually, by unipolar we never use in the one lead, that is ICDs. ICDs always and always bipolar. Unipolar, sometime if due to the difficulty we are facing, we have to do just to pace when pacemaker dependent. Otherwise, unipolar is not allowed there, because ICD is a device which is meant for one purpose, to detect VT. So ventricular tachycardia is there, na? So ventricular tachycardia should not be under detected. So we have to detect it. So if you are increasing the sensitivity, you may lose it. So that should be sensitive enough. Okay. Thank you. Today there is no breakfast because like last time I think he